So let's talk a little bit about what we know about radiation dose volume effects. This was a paper we published in 2001, and I had the idea for this based on the fact that as we started doing implants, from 1993 to about 1998, and as our technique got better, and as we mentioned earlier, we used the dual-phase electronic probe, we had more and more accurate implants. I had noticed that the incidence of rectal bleeding was increasing, and at that time there was really absolutely no guidelines in terms of what the dose should be to the rectum. And initially when we started doing the implants, our posterior row of needles was at the posterior aspect of the prostate. There was no reason we thought that that wouldn't work, and in the early years we didn't see as much because the implants weren't so good. But as the implants got better, the dose to the rectum got higher, and so we kind of laid out all this information. We did a dose volume histogram analysis of all the implants and looked at prescription doses and doses that the implant was throwing off to the prostate, and looked at how much of the rectum we were actually treating, and what we found was that there was a clear dose response. So for any given dose, the more rectum in terms of cc's of rectal that were receiving that dose, the more likely you develop what we call grade 2 bleeding, which is basically intermittent, persistent rectal bleeding caused by telangiectasias in the rectum. And based on this, we were able to establish a dose-response analysis between the implants and the development of proctitis. So if you look at this column here at the doses, from an iodine implant, these were all iodine implants, 80 gray, all the way up to 240 gray, you saw that there was a given cut point of rectal tissue, above which you would get a marked increase in rectal bleeding, and below which you would have a much lower incidence. And then when you mapped it out, we kind of found the most significant cut point was at about 1.3 cc's of rectal tissue. So anything below that, as you can see, you really didn't see radiation proctitis or rectal bleeding. But cc's above that, you did begin to see that at about 25% of the patients, if they had more than 1.3 cc's of rectum, started to develop rectal bleeding. And again, this is just kind of looking at the various cut points, and you map them out for the various doses, and this is what the curve looks like. Obviously, the higher doses need to treat a smaller amount of tissue to develop rectal bleeding, while the lower doses, the threshold is higher. But this is the most significant part of this curve, which was these, again, iodine 125 implants, was that as the amount of rectal tissue went up from 0.8 to about 1, you had an increase from 0 to about 5%. And then as you kind of got over 1.5 or 1.3, the incidence of proctitis went up to about 25%, and kind of started to plateau because we really didn't see that. So this is really the crucial thing, to really try to keep that the prescription dose from treating about 1 to 1.5 cc's of rectal tissue or less, preferably. And the issue is how does one do that? Certainly with brachytherapy, what we did was just by taking those posterior needles and inserting them at a further distance from the rectal prostate interface that we had in the past. Just doing that significantly reduced our rectal doses and then our proctitis rates. This was another article came out a few years later by Frank Waterman from Jefferson, showing a similar thing, but it was looking at rectal surface area. So the larger the rectal surface area that got treated, the more likely there was going to be rectal bleeding. There's another one looking at patients that had the rectal bleeding versus those that didn't, and looking at the percent of the rectal surface area. The larger the percentage, the patients that had the rectal bleeding had greater percentages of the rectum treated. Again, very quite obvious and consistent with our finding. And other people that have then replicated these types of studies, finding the same thing, looking at correlations between the dosimetric findings of the implant and rectal bleeding. And as you could see, comparing proctitis patients and non-proctitis patients, the RV100 is greater, hot spots in the rectum are greater in patients that have bleeding. Same thing here. So rectal volume getting greater than the treatment dose. In the controls, it was 0.6 cc's. In the proctitis patients, as you would expect, 2.5 cc's. Rectal surface area greater than the treatment dose. The volume, surface, they all correlated. So there's a correlation with either the amount of cc's or the surface area or the volume. Again, this is just another study from Anthony D'Amico's group showing, again, less than 8 cc's of rectum receiving greater than 100 gray. That's the solid line. No bleeding, grade 3 proctitis, but if you had 8 cc's or more of the rectum receiving greater than 100 gray, you had, again, 20% developing rectal bleeding. Same kind of finding with Michael Zalewski's group, looking at day 0 dosimetry, looking at the RV100, and again, if it was greater than 2.5 cc's in his hands, you had about a 10% incidence of rectal bleeding. If it was less than 2.5 cc's, it was significantly lower. Again, all kind of confirming this thing. So it's quite clear now that we know there is a dose-response relationship between brachytherapy and the dose that you're going to deliver to the rectum. This was an interesting paper published by Juanita Crook from her institution, which was saying that the time that you actually do your post-implant dosimetry to analyze this information will have a significant effect on the rectal dose. And so what you see here is that the images on the top are done, day 0. And so as you can see, when you do an implant, there is a lot of swelling that goes on. So that swelling kind of creates, and especially where their needles are placed, creates some edema, which actually separates the prostate from the rectum, and those are the two cuts on top. But then if you take another scan, the same thing, a month later, that edema has gone away, and now the rectal doses are actually higher. So it's important when you kind of look at these studies and to make an assessment of whether your implant gave a good or it was too hot. It's important to take into account when you're actually doing the CT scan. Same thing here, as you can see, if you kind of look at the RV100, that's the dose of the prescription dose covering the rectum. You can see that at day 1, it's much lower. At day 8, it gets higher, and the highest dose is at day 3 when all the edema is gone and the prostate kind of settles in closer to the rectum. But are there factors that we actually can control when we do a seed implant? And I think the answer is absolutely yes. And I think we have seen this. There was Dr. Pat McLaughlin from Michigan has done a nice study showing how the position of the seeds change on MRI, and from the time we do the implant to the time that we actually do the analysis, and that's based on the fact that we are actually manipulating some of the muscles by taking our probe and pushing it up against the prostate, and then when we take that out, the prostate and the muscles relax, and our seeds can be in different positions. But before he published that, we had seen this ourselves. And here's an example on the left of a real-time, as I mentioned to you earlier. We took these images, we put the needles in, you could see the needles, you could see what I was talking about. All my needles are at the periphery of the gland, except my posterior row is about, again, almost at some points, 5 millimeters away from the posterior wall. So that's great. So that should correspond. But then when we do a CT-based dosimetric analysis 1 month later, our seeds are right up against the rectum, and the issue is what happened. I think a lot of it has to do with that settling in, loss of edema, etc., and actually the fact that we change a little bit the position of the prostate and its relationship to the puborectalis muscles. We stretch that out, and so you can see there's things, and we actually don't have a lot of control over things like that happening. So here's just that same image kind of superimposed. What you have in the green there is the needles, and then superimposed on that is the prostate. We fused on the bone, and you can see the seeds are lower than the needles because there was a shift that occurred. And again, these are things that you can't always control. Same thing, so that the dosimetry is hotter 1 month later than it was intraoperatively. The other thing that, this is just a kind of an overview, because we want to talk a little bit about how to manage these patients, just a kind of an overview that we have on some of the factors and how we manage patients with rectal bleeding. This was kind of looking at rectal bleeding throughout our entire database. We published this in the Red Journal in 2013. And what it shows at A is freedom from greater than or equal to grade 2 proctitis over a 10-year period of time after a brachytherapy treatment. And you can see that overall the actual incidence, and again, actuarial, so it means at any time if you develop rectal bleeding, you're marked as an event, that you'll basically have somewhere about 7% of patients will develop this over a 10-year period of time. As you can see, most of these from the graph B, most of them are grade 1 rectal bleeding, and grade 2 rectal bleeding is a lot lower. Well, what's more interesting was looking at the effect of external beam radiation and the effect of hormone therapy. So what we notice is that if you kind of compare brachytherapy alone or brachytherapy with hormonal therapy, that the hormone therapy was actually protective by shrinking the prostate. So the line that had the lowest proctitis rate is that yellow line, where the proctitis rate is about is about 2.5%, and that's the group that had brachy and usually 6 months of hormone therapy. If you compare that, this is over 10 years, to the brachytherapy alone group, that's the blue line. You can see there is a significant increase in rectal bleeding without the use of hormone therapy. So hormone therapy is actually protective in this case by shrinking the prostate. And you see the same phenomena. First of all, you know that external beam, just in general, will slightly increase the incidence of rectal bleeding. You're treating more rectum. But if you add hormones to brachy and external beam combination, you lower your rectal bleeding rate. And then the issue is, what are the real significant morbidities that we saw? So grade 1 bleeding overall, just crudely, we saw over a 10-year period, 20% had this very minor bleeding. The grade 2 proctitis, as I said, was about 6.3%. We had 3 fistulas in the series. That's 0.1% of our patients. We haven't had one probably, I don't know, 6 or 7 years maybe. We had rectal ulceration seen in 6 patients, 0.2% of the overall population. And how do we treat these patients? I don't have a separate slide, but basically we try to treat rectal bleeding conservatively, just using, I'm a fan of the psyllium mucoid, and that's Metamucil or other products that are available, which I give the patient once a day. I think it creates a surface area on their stools that is less abrasive to the telangiectasias, so they bleed a little bit less. And I do take patients' hematocrits and make sure that they're not dropping that. Other than that, I advise no invasive procedure. Usually in 90% of these patients, this resolves without any treatment. But overall, if that doesn't work, if they're dropping their hemoglobin hematocrit, then I will consider them for some type of invasive treatment. My preference would be the argon laser, because I think it's the most superficial in terms of affecting that. But in our series, we've had patients go to doctors for different things, and overall, 9 patients had formalin treatment, and 18 patients underwent cauterization, which I do not recommend, because you're essentially burning irradiated tissue. So I think the formalin, we've seen some good results with that, or argon laser would be my option if you need it. So and in between that, between the Metamucil and invasive, obviously there are things like Roasa or steroid foams, which I tend to try first before moving. But again, if someone is continuing bleeding and they are becoming anemic, obviously something needs to be done, and sometimes you don't have time to wait for the conservative measures to work. So now I want to switch gears a little bit and talk about something, and we heard a little bit about it, but we've had a lot of research that we've been doing in Mount Sinai. Dr. Stone and I are involved with our radiobiologists, kind of looking at the genetics of radiation response, because we did realize that certain people tended to be prone to developing radiation proctitis, even though they may not have had particularly high rectal doses. So this is just an article looking at one particular thing, which is the ataxia telangiectasia mutation. And we had really found this very interesting graph. It looks very similar to the original graph that I showed you. But if you separate patients, you look at the entire group of patients, that's a solid black line. As you can see, that curve is virtually identical to the first curve, which was a separate group of patients. And once you get around 1 cm of rectal tissue that's receiving the prescription dose, that curve tends to go up and kind of gets to around 20% at around 2 cc of tissue. But what's interesting, if you have a mutation, and this is in a radiation repair gene, you begin to experience rectal bleeding at much lower volumes of rectal tissue. So that's that large chopped up line on top. So even at 0.7 cc's, which you wouldn't expect much rectal bleeding, we're already up to 25% of patients. So having that gene may predispose you to getting it at even very lower doses. While on the other hand, if you do not have that alteration, you can go almost to 1.4, 1.5 cc's before you're seeing any rectal bleeding at all. So it's a heterogeneous group when you look at the whole population, and embedded in that are patients that have mutations that make them more predisposed to getting rectal bleeding. This is the most recent thing that we're doing, because we're doing genome-wide association studies looking at many, many mutations, many, many SNPs throughout the genome. And the finding was, just to do the conclusion, was that the GWAS identified novel genetic markers for rectal bleeding following prostate radiotherapy, and that I think it really does point that we do need to develop a type of assay where we can assess a patient's risk of developing kind of severe radiation symptoms. So now I want to just talk a little bit about, obviously it's the same thing that I've talked about with implants does apply for IMRT, and if you can reduce the amount of external beam radiation that you deliver, you're going to get. So if you're looking at just the volume of the rectal wall treated, and you separate out for those that, this is from Memorial, those that didn't have rectal bleeding versus the rectal bleeders, you can see the rectal bleeders had more of their rectum treated with their the prescription dose. So what people have done is started, and this is probably dating back to mid-2004, 2005, is started to use rectal balloons as a way of kind of expanding the rectum and irradiating less of that. This is a study showing the rectal wall sparing effect of 3 different endorectal balloons, and again showing that by doing that, by expanding the rectum, you were able to certainly spare the posterior part of the rectum. So what a lot of these studies don't show, but is a phenomena, is that as you do this, there are 2 phenomena by blowing up the rectum. You are clearly going to spare the posterior wall, but there is no question you're also going to take the anterior wall and push it into the higher dose region. But these studies were just really primarily looking at something. And you can see that here, the rectal balloon on figure A versus B. So you're sparing more of the posterior wall, but you are getting probably more of the anterior wall in the hot spot. This is results there, again, looking at the ratio of the total structure, which again, this is just a DVH, and you can see that with the rectal balloon, you're getting lower doses to the rectum, the whole rectum, or percentages of rectum, because you're expanding the volume of the rectum. Same thing as why do we have patients drink water prior to radiation? Because we expand the bladder, we move parts of the bladder out of the radiation field, but in terms of cystitis, we still have a portion that's going to be in the high dose region. This is kind of another study looking at reduced late rectal mucosal changes after prostate 3-dimensional conformal radiotherapy, looking at endoscopy findings. And again, just looking at these endoscopy findings, it shows you getting more of these kind of telangiectasias in patients without the balloon, and once you use the balloon, you get lower incidence of these endoscopic changes. Here's another paper, reduced late rectal mucosal changes after prostate 3D conformal with endorectal coil balloon and repeated endoscopy. And again, just look at the images there without the rectal balloon. These are dose distributions. The red, you can see that it's covering a greater percentage of the rectum. But if you look at with the rectal balloon, because you're expanding the balloon, it's occupying a small percentage. But if you look at the red, to me, the volumes look similar. So you still get a portion in the anterior wall that's getting the full dose and perhaps even more dose. So again, my personal experience, again, I'm nothing against the balloon companies, was I actually saw in my own anecdotal practice a higher incidence of bleeding when I started using rectal balloons, and I have personally stopped using it, but I just wanted to bring this up and show you what's out there in the literature. This just shows that obviously, and we found this as well, patients do get quite comfortable with using the balloon and are able to tolerate it very well. So now let me talk, I know there was a morning discussion of this, so I don't want to spend too much time, but I will end on talking about these absorbable spacers, hydrogel. There's no question, this was basically a study of patients undergoing prostate cancer radiotherapy, 12-month toxicity and proctoscopy results of a prospective multi-center phase 2 trial. You can see the image on the left. A is without the hydrogel spacer, and the one on the right, as you can see, that structure outlined in blue is with it, and obviously you are just pushing the prostate away and obviously sparing the rectum significant doses. And this is just looking at the Vienna rectoscopy scores. And if you say 0 is no changes at all, and 3 is the most, you could see that that using the spacer hydrogel, you had a lot more zeros and then 1 versus if you did not. So clearly that pushing the prostate away from that resulted in lower radiation changes. This is just an article looking at 2 different rectal spacers in prostate cancer radiation, looking at a balloon and a gel, and those are the curves there. There's not really as much difference as you would think in these graphs in this particular study where they used a gel. This is another paper looking at hyaluronic acid, and again you can see the MRI by just kind of creating this physical space. You will reduce the dose to the rectum. So this is how the hydrogel is placed. The needle is placed in the space between Denavier's fascia and the rectum. Water is injected in there. It opens up the space. Once you see that opened up space, you then you have these 2 canisters that mix the 2 compounds together, and you create this substance. The polyethylene glycol hydrogel is injected into that space. So here's just a picture from another article from the trial. You can see before the spacer and this MRI, prostate, rectum, and now you see after external beam, 3 months, you see the spacer, and then 6 months, that spacer is resolved. This was just using another article, another approach using a disposable biodegradable balloon. This is another article from the Hydrogel Prospective Center trials, again showing how the spacer reduced the rectal DVH and dose to the rectum. And finally, the most recent is from Larry Karsh talking about this. And what's interesting here is that there are some clinical outcomes that they measured. So if you looked at rectal pain adverse reactions with the spacer, 2.5%, 11% with the control arm. So let's just look at this. Late grade 2 rectal toxicity, you had 0% in the spacer arm and 5.7% in the control arm. And there was interesting other types of things that they observed. Bowel quality of life was much better in the control arm getting the spacer versus the patients not getting it. But then this was interesting. Potent men at baseline retaining erections sufficient for intercourse. 66.7 with the spacer arm versus 37.5% with the control arm. So is this sparing neurovascular bundle radiation? There's a suggestion here that perhaps it might. And other things. They had other things such as bowel, urinary, and sexual quality of life, and again, lower values or better quality of life with the spacer. So I think this is really being widely used. I think certainly many of us are using this in our practice. Only caveat: it is a separate procedure. It needs to be done. I'm not for those of you doing it. Some are doing it in the office. Many are doing it in the operating room. So there's the time involved. If you feel that you do whatever technique you're using, you are seeing a lot of rectal bleeding, then this is probably a really good thing to check out.